Well, everyone, good morning, everyone. Thanks so much for being here. And also special thanks to Dr. Peter Pompei for our time this morning. You know, the topic is pretty, serious and heavy, and it's profound as well. Just to remind you of the topic today, communicating my wishes if I am seriously ill. Well, sickness, illness, life and death is part of our life cycles. Maybe the God uh, said it that way. And simply, it's hard to be part of that rhythm too. I want to share my sort of personal mantra, my spiritual life and physical life as well. It's a Jewish Rabbi Abraham Joshua Herschel's quote: "Just to be is a blessing, and just to live is holy." So even though maybe I'm not a scientist, our body is kind of a composition of cells. Is that right, Dr. Peter? Mhm. But I mean, I'm a firm believer that we are more than just cells, something we call it holy life. And then personally, I believe that community is much bigger than, larger than just uh, myself. So from that perspective, it is a great blessing that we live and we have relationships, and also we have a community here. So I hope that our time will be more valuable and meaningful, and also something that we can ponder and then even deeper to find the mystery of God's presence among us in our lives. So let us pray and then let's move on our topic together. Dear loving God, we give you thanks for this beautiful morning that brings us together in this life moment within this blessed community. As we share this sacred moment together, we ask for your humility to fully recognize and honor your majesty and grant us your peace and grace so that we may fully comprehend the touch of your grace upon our lives. May this time together deepen our understanding of life and our recognition of the divine mysteries within us. In the name of Christ, we pray. Amen.
Amen.
I want to turn to Kyle for housekeeping this online community. Kyle, lead us off.
Good morning, everyone. So as Peter is doing his presentation, I would like everyone to stay muted as much as possible. Peter will be doing interactive with you guys. So if you guys have any questions, either raise your hand in the screen or use the reaction hand raise. And yeah, let's have a great conversation. Take it away, Terry.
Okay. Also, we are being recorded, so please know that. And Kyle, happy vacation, and thank you so much for spending time with us because we really need you and we appreciate you.
You're welcome.
Welcome everybody. I'm Terry Morrison, and I'm so happy and honored to introduce our guest speaker today, Dr. Peter Pompei. Many of you know him as Jenna's husband, as Phil and Sam Pompei's dad, and as grandpa. He has 3 adorable grandchildren who are in church every Sunday. So many of you know that part of Dr. Pompei. But on a more formal note, he is a general internist and a geriatrician with 30 years of clinical experience. After graduating from the University of Chicago Medical School, he completed his residency in internal medicine at the University of North Carolina. Dr. Pompei then pursued a research fellowship in general internal medicine at Cornell University, where he focused on comorbidity and predictors of mortality. He then returned to the University of Chicago, where he served as fellow director in geriatric medicine and studied delirium in hospitalized patients. In 1993, Dr. Pompei joined the faculty at Stanford University, where his work included being the director of the Fellowship Geriatric Medicine and Associate Program Director for Internal Medicine for residency and instructor for clinical teaching seminars of the Stanford Center for Faculty Development, and is an inaugural member of the Educators for Care. They must have cloned him a million times for all those many, many jobs. Dr. Pompei has received numerous awards, and some of these include the Henry Kissinger Family Foundation Award for Excellence in Clinical Teaching, the Department of Medicine Chief Residency Teaching Award, the Department of Medicine David Rydam Clinical Teaching Award, the Arthur Bloomberg Award for Recognition of Excellence in the Teaching of Clinical Medicine, and the Oscar Salvatore Award for Exceptional Service to the Stanford Medical Students and the School of Medicine. Wow, that's just a
Wow.
few of
That's
them. Dr. Pompei has been active in the work of American Geriatric Society's efforts to infuse geriatric principles into surgical disciplines. And he also volunteers for AFS, which is a foreign exchange student program for high school students. And without further ado, I certainly welcome Dr. Pompei, who will speak with us on communicating my wishes if I am seriously ill. Welcome and thank you, Dr. Pompei, for spending time with us.
Thank you so much, Terry, and thank you, Pastor Zhang and Kyle, for helping put this together, and thank you all for your willing participation in this session. Let me begin by acknowledging that Zoom is not my favorite modality for interacting with folks, but it's convenient, and I'll do my best to try to engage people as best we can. The size of the group is also somewhat large for meaningful interactions over Zoom, but we'll do the best we can. So thank you again for your participation. And what I hope to do in the next several minutes is to talk to you about advanced directives. And we'll begin by defining them, talking about their value or potential value, and then look specifically at a couple of options for us to consider as we reflect on expressing our wishes if we face serious illness and are unable to communicate directly with our family and our physicians. So some of you, I'm sure, have advanced directives, and I'm sure many of you have thought about advanced directives before. And so I'm wondering if anybody would be willing to start us off by just telling us what your understanding of an advanced directive is.
Well, this is Les.
Okay.
I think the California Medical Association has a form of it, and Palo Alto Medical Foundation and others provide them. But my understanding is that an actor, an adult who's competent, may make known their wishes as to how they'll be dealt with medically in the event that they cannot make a decision for themselves. And when we filled it out, I found that the challenge was that it seemed there were three broad choices: do nothing or very little, do everything possible, and then that broad middle ground, and so we've checked the broad middle ground, but I've many discussions with my wife and then our adult daughter, because our son lives in Brazil and we're not dividing that responsibility in order. And then I've tried to supplement that with something like, I want to add something. Economics should play a role. Please do not dissipate everything I worked for my whole life in the last 9 days of my life, with heart thumping procedures if the outcome is clear, because I want to save for it. So I'll stop talking, but that's, and I think it has to, maybe that has to be witnessed, and you make the decision when you're sound to deal with times when you cannot make the decision for yourself.
Thank you. And that's exactly right. And the point here really is that the correct term, I've seen it advertised in different ways, even in for this session, is that it is advance and not advanced with a D. Because the point is that we're making our wishes known in advance of a time when we may not be able to express our wishes to the people that might matter. And those wishes can be advanced in terms of their detail, or they can be very rudimentary or elementary. So it's not a matter of being highfalutin, so to speak, directives, but just the fact that they're being offered in advance of a time when we may not be able to express ourselves and say what we would like to have done for ourselves. So so let's move then to the value of such a document or such an expression. I would posit, and I think as Pastor Jung was talking about, that the end of life is important. It's important as the beginning of life in many ways, and it's not uncommon for people to plan fairly substantially for the beginning of life. And so it's not unreasonable on the face of it to think about planning or expressing ourselves, our wishes, our hopes and dreams for the end of life. And this is important, especially for family members with whom you may or may not have had conversations about this. This is not an easy topic, and many may feel uncomfortable discussing this with friends and family. And so if it's actually recorded somewhere, it alleviates the stress that families face in trying to make choices on your behalf if they don't know what it is that you would have wanted for yourself. And so it's a gift to your family. It also it lets you talk about a sometimes uncomfortable topic, which stretches us and allows us to go beyond our comfort zone and talk about things that many of us don't really like to talk about. And finally, I can't emphasize enough the tremendous benefit it affords the healthcare team. Many of you recognize that when serious illness arises, you may be under the care of physicians who you've never seen before. You may be in a hospital where you've never been before. You may be faced with circumstances that are completely unknown to you and to them. And so for them to have access to information about you in terms of the things that are most important to you, that can be extraordinarily valuable. And it's too often, in my experience, with a seriously ill hospitalized patient, where there can be significant disagreement among family members. Some may say, let's try to do as much as we possibly can. Others may say, I don't really want to put them through these kinds of things. And so making a decision can be based on what you prefer and what you've expressed as an interest of yours, as opposed to relying on decisions from family members who may not know fully what it is that you want to know or what you would like to have done. So while this on the surface seems like it has adequate value, I mean, there's no reason to think that this is not potentially valuable exercise and something that many of us should engage in, there still is some resistance. And some of that resistance, as I've already alluded to, is the reluctance for us to think about the time when our time is short. Many of us don't like to think about our impending death. Yet all of us know that all of us will die. And so overcoming that barrier is the first step in engaging in these kinds of conversations. The other, and related to that, and I've seen this in many circumstances, where there are individuals who honestly believe that by thinking about bad outcomes, they're somehow going to be conjuring those bad outcomes up. So if I think I'm going to develop cancer and what I want to happen if I do develop cancer, that somehow that will allow the cancer to develop in some ways. So it's kind of magical thinking, but it's not uncommon. And there are certain cultures where it's actually quite common. And they, whenever you try to bring these topics up, they say, no, we can't talk about that. That's not something we want to talk about or raise. So that's another potential area of resistance. And then a third area that I see not uncommonly is concern of people for being in opposition to the medical authority. So if your doctor recommends a particular strategy or a particular intervention, you say, well, they know best. They went to medical school. They know all this stuff. And so we're going to have to defer to them. But that doesn't always take into account what's most important for you as an individual. And I'll give you one very quick example of that sticks with me over the years is that I was caring for a monk from the Eastern Orthodox tradition who was being treated for an advanced cancer. And I was looking after him in a nursing home at the time because he was too sick to travel the distance from where his monastery was to the hospital every day. So he was staying in a local nursing home and going back and forth for chemotherapy. And every time he came and went back, he was miserable. He was just uncomfortable and suffering from the treatments. And so we had a long conversation about what it is that was important to him and what he really wanted for whatever time he had remaining. And he shared with me that he really wanted to return to the monastery and to spend the last days of his life with his brothers in the monastery. And so I contacted the head brother, I guess, I'm not sure exactly what the terminology is, but of the monastery, and shared with him this desire and wondered if they would be capable, comfortable, able to provide the necessary support and care for him if he were to come home. And so they assured me that he would be, that would be no problem. And so we arranged for him to stop his treatments at the hospital and to return to the monastery to spend what days he had left in the situation that he wanted. Now, I didn't make any friends among my colleagues in oncology who were treating him because they were very unhappy that I made that happen. But I think it was the right thing to do for that individual. And I had to, I really wanted to respect his wishes for what was most meaningful to him and his family, brothers at the end of his life. So those are some ideas about the resistance to, even though there are benefits to this, to an advance directive. There are also some legitimate limitations to advance directives. One of the things that is important to recognize, and I think many of you may have experienced this already, is that the portability or the exchange of information among and between healthcare settings and healthcare systems is far from perfect. And so if you have the information in a place that you feel is secure in your medical record locally, and you happen to be traveling somewhere and something unfortunate happens to you, access to that information is not going to be necessarily readily available if you're relying on the medical record to be the place where that information is stored. So portability is definitely a concern and an issue, and that's why I would strongly encourage all of us to, as we develop advanced directives, to have copies available to ourselves or to our family members so that we can share these in a situation where they may not be accessible through the usual channels. Another potential limitation of this is that I think we need to recognize that it's impossible for us to predict how things will turn out, how things will end up, what things will be like. And so having an advance directive may provide us with a false sense of control. We may feel that now, okay, I've expressed that this is what I want to be at home, I want to be surrounded by my loved ones, et cetera, et cetera. But something may intervene that may make that impossible. And that's just something we have to recognize. We don't have complete control. And again, if we go back to the analogy of childbirth, the same thing happens, right? I mean, we may all say, okay, I want to have the baby this way, I want it at this time, it's going to come out this way, everything's going to be fine. And then there's some crisis. And everything changes, and you have to make adjustments based on whatever the reality of the situation is. So while planning has definite advantages, and I think there are good reasons to think about this, we shouldn't be comfortable in the sense that just because we write it down or just because we express our wishes, that they will definitely happen. And that's just part of life, that we can't control everything. So let me pause here and see if anyone has any questions or reflections or rebuttals, anything that anybody wants to talk about before we move into some specifics about a few examples of advanced directives.
Oh, Sandy raised her hand. Cindy, you're
Yeah, there. Now I'm unmuted. I had an experience a couple years ago where I ended up in the ER, and they decided that I needed to have a pacemaker. And I had this thing with me, and they said, well, you need to withdraw that if you want us to do the treatment, because we expect that you will survive this, and you want to we can't do the surgery with this as it was. And so of course I had my wits about me, and I said, yes, please withdraw it.
Yeah,
so it's just that it is something that you can withdraw if you have the mental facility to be able to do so, and you're in an emergency situation.
That's absolutely right. And these can be changed anytime you want them. I mean, just because you write it down once doesn't mean it has to stay that way forever. You may change. And as your circumstances change, you may really decide, this is really not what I want. I would like something different. And I think the example that you gave, anytime you call 911 or present in the emergency room, the presumption is by the treating folks there is that you would like to have something done for you. Otherwise, you wouldn't have called 911 or you wouldn't have gone to the emergency room. So they will not pay too much attention to your advance directive for immediate emergency procedures. And similarly, for any elective operation, the idea is that you are like a placement of a pacemaker. If you are asking to have a pacemaker placed, then they want you to suspend any advance directive that limits your treatment options because you have made a choice to go ahead and proceed with a particular intervention. And that's completely legitimate. Yes. I see Terry's hand, and then I see Meryl's hand.
Terry, you want to go ahead?
Okay. A lot of people have confusion over feeding tubes. And some people say, check, I want it for 3-month trial kind of thing.
Mm-hmm.
And so it's hard. And then after 3 months, if they haven't changed, then the family, decides, well, they follow the advance directive to pull the tube. And that's a really, really hard thing. So do you have any thoughts about feeding tubes? Say somebody has a stroke and, they can't swallow, for example, and so they have a temporary feeding tube.
Mm-hmm.
Thoughts about that?
Yeah, if you don't mind, Terry, I think we'll hold on that for just a minute, because I'll talk a little bit about that as we get into some of these specifics of advanced directives. But that's a very important point, and another issue with the way advanced directives are often written. So thank you for that question.
Okay.
I think Judith has her hand up, and there may be someone else, but Judith, please.
Yeah, don't
Hi. Good to see you.
Good to see you.
I
have been involved, especially down in Southern California when I was there for 5 years, in the Pulse Coalition. And even though the training kind of recommends that you not fill out a PULSE form, the physician order for life-sustaining treatment, unless you are within, say, a year of dying or chronically ill. I found that a lot of us on the coalition wanted to have an PULSE form after doing an advance directive, because our understanding was that doctors have to follow that, whereas they may not follow your advance directive. So what is your thought about when is a good time to do a PULSE form?
Thank you, Judith. That's another excellent question. And that's another topic that we're going to get to in just a minute. Maybe I should have waited for reflections until I'd cover a little bit more material, but we'll get into that. And that's a great question.
Rural Dunker has a
Yes.
opinion.
Yeah, sorry. So I'm not quite sure how to frame this one. Somebody, I think Sandy mentioned that you can change your advance directive through time. Do you have some ideas about how to navigate the issue of someone who has an advance directive? And as we get older, many of us end up with some cognitive issues. And so if that's in play, and if there are conflicting ideas about what should happen, how do you navigate that? What was said at the time when one was totally competent, and then as people become maybe less clear in their cognitive thinking, and yet that doesn't mean that the feelings that they're expressing may not be totally valid. So for the person who is managing the care at that point, how do we take those two things into consideration and figure out what truly is wanted and is the right thing to do at that point?
Thanks. That's a terrific question. Probably one of the most difficult to address is when cognitive impairment intervenes, and it's really, do you want to base your decision on what the person has said when they were well, or now that they've developed a cognitive impairment, should we be more respectful of what they're saying now? And that's a very, very difficult situation to be in. And that too, I think I'll help address as we get into more specifics about the specific options. Any other comments or questions before I delve into those things? Judith, you okay?
I have one more comment.
Okay.
It happens that the 17th, the Fresh Air on NPR had an interview with a death doula.
Right.
Her name was Albua Arthur, and it was a 37-minute or so excellent talk. So I recommend that. You can find it after, it was recorded, so you can still find it.
Yeah, that's good. The death doulas are becoming more prevalent, so that's interesting to talk about that. All right, well, let me just cover briefly some options for advance directives, and then we'll have plenty of time after this for further discussion and some of the nuances that you all have already brought up. So I would say that probably one of the most well-known advance directives that people talk about, or that you hear about and you see on television a lot, is the DNR order, which stands for Do Not Resuscitate, which actually should stand for, or should be abbreviated as Do Not Attempt Resuscitation, because there's Do Not Resuscitate suggests that you're going to always be able to resuscitate the person, which isn't true by any means. And so the question is, do you want, in the event of your heart stopping, for them to attempt to revive the heart rhythm by pressing on your chest and breathing for you, et cetera, et cetera. And so that's kind of the classic initial, and that's what was available for many years, was this so-called DNR order. And that's part of, as many of you have said, part of many other advanced directives where the first option that you can choose is do nothing, which would be the DNR part, or do something or do a little bit, but not everything. So that's the kind of most rudimentary advanced directive, and it's something that you can choose if you want. One of the things that I find amusing is that many of the medical residents, the trainees that I work with, having been in the hospital and having attempted resuscitation on many older individuals, commonly say they want to have DNR tattooed on their chest because they don't want that to happen to them. But I can promise you that if they're coming home from a shift and get hit by a bus and need to be resuscitated, they're going to want to be resuscitated. So I think the idea of do not resuscitate sounds good, that you don't want to go through the pain and suffering associated with restarting the heart in the event when you're very advanced in advanced stages of illness. But when you're young and healthy, I think people would rescind that idea and agree to be attempted to be resuscitated. So the other, another sort of higher level option are advanced directives, which list a variety of medical interventions that you do or do not want. And so this gets to both reviving the heart by chest compressions, but also includes things like a breathing tube. Would you want to be put on a ventilator with a breathing tube in place if you needed that? And for how long? Would you want to have dialysis if your kidneys failed? And would you like to be on an artificial kidney machine for some time? Would you like to have a feeding tube, as Terry was mentioning, if you were unable to sustain your nutrition on your own? And those are worth thinking about, and they're worth reflecting on. But again, because it's so difficult to know what the specific circumstances you might be facing are, it's there are many different medical interventions that are possible, that you can't possibly cover all of them by making a list of the things that you would like or would not like. The other limitation, as Terry pointed out, is that for how long would you want this? I mean, we all know stories about people who've been in coma for months or years and then still awaken. And so do you want to take that chance, or would you prefer not to, as Les was talking about, break the bank by supporting you over those many months and years for the rare chance or rare circumstance that you might be revived? And this also gets to, this is an example of what Judith was talking about with the POLST, which is, as she said, the physician orders for life-sustaining treatment. So the difference between the POLST and other advanced directives is that the POLST is actually a physician order. Most advanced directives, when you write down, I do not want to have dialysis, I do not want to have a breathing machine, you don't need a doctor to sign that statement. All you need to do is write it down, and it's nice if you sign it and have a couple witnesses, and then it should be respected. But a physician order is different, and so if you decide using the POLST form that you don't want certain things or you do want certain things, the physician signs them. That is actually the same as if they write for an antibiotic or anything else for you, and that is expected to be followed no matter what in the circumstance where you're unable to make your choice about things. So we moved from fairly rudimentary things like DNR to lists of potential medical interventions, which you can't possibly be exhaustive and are difficult to know under what circumstances and for how long, and POLST, which is a physician order. Another completely different approach to this, and one that I'm going to recommend to you, and I've put a couple of references for you in the chat, are what most people would refer to as values-based advanced directives. So this is less about saying, this is what I want, this is what I don't want, et cetera, et cetera. But this is what saying, these are the things that are important to me. This is what makes my life worth living. This is how I want to spend whatever time I have left. And to actually write those down. And they can be a whole variety of different things that you come to for whatever's important to you. In the book that I reference in there by Atul Gawande called Being Mortal, he talks about the end of life for his father. And one of the things that his father had in terms of what meant something to him was being able to eat ice cream and watch baseball. So as long as he could eat ice cream and watch baseball, he was willing to continue the fight. Once those things became either impractical or impossible for him, he would not find life worth living and therefore would not want to continue, would not want to continue. And so your expressions, like it can be, they really can be anything at all that's relevant or important to you. I mean, as I've thought about this for myself, I can share with you, the one thing that matters to me is that the grandchildren that I have are old enough to remember me. I mean, it's kind of egocentric, I know, but I mean, I look forward to the time when they get to be at least 5 years old, where they'll be able to remember me. And part of that is because my father died when my younger son, Philip, was 3 and we were leaving Chicago. And he has very few memories of my father, even though their bond when we lived there was very strong. But he, you know, given the fact that brain development happens the way it does, he does not have any memories of my father, which is, I think, sad. But, you know, it's not the worst thing in the world. It just, but my preference would be that my grandkids would have a memory of me. And that's what I could write in one of these values-based approaches. So I'm offering you 2 different examples again in the chat. The one that's been around for quite a while is something called the 5 wishes. And I'm not sure who developed this, but it's a document that you can complete, and there's a template on the website for you to do. The disadvantage in my mind about this one is that it's proprietary, so you have to pay for it. I don't know how much it is because I never paid for it, but I'm sure it's not a lot, but you do have to pay for it. And the things that they ask you to record are what person you would want to make decisions on your behalf if you're not able to make decisions on your behalf. And that gets to the question about, or the point about somebody who's demented. So if I have identified my wife as my surrogate decision maker, if I'm unable to make decisions for myself, and I become demented, and I say, okay, before I wanted this and now I want this, she will be in a position to do the best she can to say, over the course of my life, what's been important, what would I value, what do I want, and make a decision based on that knowledge. So identifying somebody who knows you and can make decisions on your behalf is very important. And writing that person down and then making sure that they understand what it is that you want. So it's not enough to say, okay, I want my son to make decisions on my behalf and never having had a conversation with him about what's important to you and what you really care about. So the first thing would be to identify a person and to communicate with them what the things that are important. In this document in 5 wishes, they do return to the intervention. So they do say, would you like this? Would you like feeding tubes? Would you like breathing machines, et cetera, et cetera. So you can incorporate that list of interventions after having identified who the person that would make decisions on your behalf. It also emphasizes the role of comfort. How comfortable do you want to be? How much would you tolerate narcotic medications, even if they cloud your mentation or if they precipitate your demise? Would you be still willing to want to have strong pain medications in that situation? And then how would you want to be treated is another category. And this has to do with, do you want to be at home? Do you want to be in the hospital? If you're at home, would you like your family to look after you, or would you be happy to have strangers come in? And I don't mean to be derogatory there, but have people that are unknown to you come in and change your bedclothes and help you to the bathroom and that sort of thing. And then finally, what you want to tell your loved ones as you pass. So those are the 5 components of the 5 wishes, and there's a template there that allows you to go through the different ones and fill that out as you wish. The other example that I recommend that I've used more commonly is something called the Stanford Letter Writing Project, and this was developed by a colleague of mine who suggests that the advance directive take the form of a written letter, and that it has to do with what we've talked about is what matters most to me. What is it that matters most to me that I want to share with others in the event that I'm unable to share this on my own and I'm nearing the end of my life. So it identifies, again, what you care about, whether it's ice cream or grandchildren or whatever it is that you care about. It also gives you an option to identify future life milestones. Like if you really want to live to your 80th wedding anniversary or whatever it is that you're thinking about, that would be important consideration for those taking care of you. It also, again, very importantly, asks you to identify who I want making decisions on my behalf if I'm unable to make those decisions. And it lists more than one, you can list more than one person. You should rank order them so that, there's not competition between them. But if you want first my wife, and if she's unable, then my son, et cetera, et cetera. Can't emphasize enough the importance of identifying somebody to make decisions on your behalf. And then again, it returns to the things that I do want and things that I don't want in terms of medical interventions and pain management. So both of these are, and then this one is free. It's available on the website that you see. It offers a letter both about what matters most to me, but it also, there's another template for a letter that says, what is it that you want to say to your loved ones? So it gives you an opportunity to write a letter, sharing your thoughts about yourself, about the future with your loved ones. And so those are 2 value-based advance directives, neither of which require anything more than filling it out and having it signed and witnessed by 2 individuals. It doesn't have to be notarized. And then the most important thing we talked about, portability, is you can either send the letter to your doctor or upload it onto your medical, your electronic medical record, whatever works in your whatever system you're in, and carry around a copy so that you can share it in a situation where you're not in the system that normally takes care of you. So that's a lot, I suspect. I hope it's something that you can think about, and I've given you the references and resources in the chat, and Kyle has a question.
I actually have 2 questions.
All right.
First question I have is there a specific age where you are not allowed to create an advance directive, or are there specific situations? Like, for example, I remember getting one as an 18-year-old due to my disability and unknown how long I would be around. So is there like an age limit to when you're allowed to create an advance directive?
Okay, that's one. What's your other one?
And the other one is I was told that family members were not a good source for advance directives because they could potentially be biased in a sense. So I'm kind of curious as to, because I was told do someone that's not a family member so that, it's not a biased kind of thing.
Yeah, thanks, Kyle. Those are 2 great questions. So first of all, there is no age limit. You can do this whenever. It's obviously most relevant for people who are likely to be facing the end of their life, but it's not limited to that in any way. And that's why I was talking about the residents who are, in their mid-20s who are saying, I want DNR tattooed on my chest. So it's possible at any stage to do this. But they're most relevant, obviously, as you're nearing old age and the end of your life, or the last quarter of your life, however you like to think about it. So that's when they're most relevant, I think. In terms of family members, again, I think if you've had a conversation with the family member you identified and say, look, this is what's important to me, this is what I want, this is how I want things to go, then hopefully they will be true representatives of you in a situation. Sure, they're going to be biased. I mean, nobody wants to say, oh, sure, let them go. But they also have to take into account, if you strongly encourage them to, you know, have this conversation, then and agree to their wishes, then I think you can rely on somebody in your family to represent you. Let me just finish quickly, and I'll come to Sue's question in a second. This gets back to the question about the age, when you should have a POLST. It is true that the POLST is most commonly initiated for people who have 6 months to a year or so, when it becomes pretty relevant to their outcomes. But there's no reason. I have a POLST, and I hope I'm not going to go in the next year, but who knows. So there's no reason not to do it, and you can always change that too. You can you know, revise your POLST and bring it in and have the doctor sign a new POLST. So, yes, Sue.
Well, we brought up the post form, and I'm not sure if everyone has seen it or knows what it is. I happen to have a blank one because I had a conversation with my physician last year on my medical form. So this is the post form, and I was always taught, recommended for when paramedics, etc., come into the house. And I had an experience a couple years ago. Fuzzy, please. The neighbor, I had to call 911, and it was one of the first things the paramedics wanted to know because she was 88 years old. And so I knew what she wanted, but they needed to see this because I wasn't on her advance directive. So that's a post form. And then I had a fall last year and ended up with Stanford's farewell to fall programs, and had the OT came in, and there's this other thing that can go on the side of the refrigerator. It was developed by the County of Santa Clara Emergency Services. It's called Life File. It's just a single page. It's on the side of my refrigerator. Tells me who my primary care physician is, my allergies, my surgeries, and who to call if somebody's in the house that needs to know. So that's, and I thought that was pretty nifty. It doesn't do all that the POLST does, but it gives them a quick reference on the side of the refrigerator of things about me. So just some information.
Yeah, that's very helpful. And that, again, it really speaks to this concern about portability. I mean, if you call 911 and they have no idea that you have a POLST form, they're going to do everything that they can possibly do. And so having these documents readily available for others is going to be important. And I don't have any special knowledge about how to do that. Some people post it on the refrigerator. Some people actually put them in a vial and keep them in the refrigerator. There are a variety of things that people have tried, but the real concern obviously is that the information not be shared with the people that need it most in a timely way.
Sandy, raise your hand. Oh, Les?
Well, I had an observation and a question. It seemed to me that the advanced directive that we have was more of a direction to the physician. So my wife, who has the power, and after that, our daughter, we have these discussions. That's helpful to the physician. But I've also been writing out my values, not directed to the physician, but directed to the person that hold the power, my spouse and daughter, because it seems to me that's sort of an ongoing discussion and not really legally binding on the doctor. But for example, when to move from the hospital, and how about hospice care as opposed to life-extending procedures. And it's not arithmetically calculated. As you say, you can't anticipate all these events, but more value-based. Does that seem the way to go? And you don't have to have that witness. That's just maybe a handwritten or letter that directly to your loved one.
Yeah, no, I think that's great. And I think you're right. The audience here is twofold. It's both, I mean, in many ways, threefold. It's you. First of all, you have to think about these things and make some decisions. Second, it's the people that you care about and that you love, so that they understand too where you are and what's important to you. And then third, the potentially treating physicians. And again, the advantage of the Stanford letter writing project is that it offers two separate ways to write these letters. One directed at the physician, and it's a very nicely worded letter to the physician. And then the other one is to the family members, where you can express your wishes.
On
And again,
Kyle's
go ahead.
comment, I recognize we all have biases, but of course, medical have biases.
Yes,
As you put it.
absolutely.
Oncologist wants to do everything, and
Absolutely, yes.
the personal physician may be more respectful of those ongoing statements. Also, I think, as you pointed out, you have to take care if you have two siblings not to just give it joint powers, but to communicate as best you can to avoid that after death rivalry and conflict. But otherwise, there's a tussle between them, and these decisions are not like a joint executive decision later that can be thrashed out over time. They have to be made on a real-time basis.
No, I think that's exactly right. And that's again speaks to the value of having these for sure, and having the conversations and discussion.
Thank you.
Thank you.
By the way, my grandfather died at 102 in 1996, and he was a Chicago Rush Medical Center grad.
Wow, that's awesome.
I was an American.
Lori,
Are you still involved in AFS?
I am.
I was a 1958 AFS student, 300 miles north of the Arctic Circle, working on a farm in Finland.
Wow, that's amazing. Yeah, we still have an active chapter in the Bay Area.
Was that right?
Yeah.
That's great. Good to talk.
Hey, Peter, this is Bob.
Lori Draper has one.
I had a question for you. We have the Advanced Healthcare Directive from the state of California, and I was told that the physicians tend to pay more attention to that. How does that fit into what you're suggesting here and comparing it to Pulse as well?
Yeah, so as Bob, thanks for that. There are many forms that are available. You can look up advanced directives online and you'll find lots of different options. The state of California has one, the California Medical Association, American Medical Association, a variety of them. I don't think necessarily one is better than the other, and I think they're all looked at by the physicians with the same degree of value. So what's different again is the advanced directives are sort of a list of what your wishes and preferences are, whereas the PULSE is an actual order to the physicians. If I'm coming into your emergency room, do not attempt resuscitation because I don't want that to happen. Or don't put a feeding tube in me under any circumstances. Until you change that, that's what they're going to live by.
Thank you.
Sure.
Yeah, Lori?
Yes, I have a question on the PULSE comes in an actual form.
Yes.
And is there a line for the value-based directive that gives you some idea, as well as Stanford letter writing? Are there some forms available?
Yes. Thank you, Lori. That's a great question. And both the 5 wishes and the Stanford letter writing project offer a template, in other words, a form for you to fill out with very specific prompts. So in case you don't really know what to write in a particular thing, they give you some prompts. So it helps stimulate your thinking about it and helps stimulate a discussion. So I think both of them have value from that perspective.
And how do you obtain them?
So I've listed the websites for both of them in the chat, but Kyle tells me that he's going to circulate that information some other way so that they don't disappear. But if you need them, you can contact me directly and I can help you get to whatever you need.
Thank you.
Sure.
Sandy has a question.
Okay.
Sandy, go ahead.
You're muted, Sandy.
Still muted, Sandy.
Somebody muted me, okay. I have a 7 or 8 page legal form that was done by my attorney a couple of years ago, a healthcare directive. It has a lot of legalese in it. And I like the idea of that letter writing project, making it a little bit more human and gentle and so forth. Can I have both?
Absolutely.
Yeah.
As long as they're not in conflict,
Right,
direct
I mean-
conflict, like one says one thing and one says something else, then it's hard to know what to rely on, but absolutely.
I would like to take the legal version because and make it more humane. So it's something that my son can have and work with, or if he's not available, my nephew, who's an attorney in Pennsylvania.
Mhm.
But the language in this thing is just so
Different.
complicated.
Yeah, I had exactly the same experience with when we were developing our trust, and I thought, whoa, I don't even know what they're talking about here. So
On the other hand, as a layperson, when I looked at the 5 wishes recently, I don't have any sense of what I would want in those situations. It's mind-boggling. I mean, I wouldn't know when to pull a plug and all this. And after listening to you today, I probably wouldn't do that. I would rather, but have a timeline and also have at least 2 doctors confer that what their reasoning is of why I should let go, and so that I know when I had to take care of my aunt and she was on a feeding tube and I was I just didn't know what to do. And the physician called me and he said, if that was my aunt or my parent, I would let her go. And that was what I needed. I needed that. But as a layperson, when I looked at that 5 wishes, I couldn't fill it out. I don't know if I want a feeding tube or this or that. I'm not a physician. I'm not in the medical field.
and
The value things I can fill out, but those other things, it made me just go, I couldn't face it.
yeah, thank you, Joy. That's a perfectly legitimate and understandable situation, and that's why it's very difficult to use the advanced directives that are purely about what I want and what I don't want, because you're not always in the best position to make that decision. And hopefully, your physicians will have discussions with you about this, and knowing your values over the course of your life will be important for them as they work with you and your family to make the right choice for you. So it looks like we're at time. I don't see any other questions or comments, and we maybe we've gone over 3 minutes. Let me just conclude by again thanking you for your participation and for your involvement with this. And I wish for all of us that we can think about this topic of what we want when our time is short, and to write it down and to have conversations with the people that are meaningful to us, knowing that we're not going to be fully in control of what happens, but at least we're going to be expressing what it is that's key for us.
But like you said before, it doesn't have to be notarized or anything.
No.
Correct?
No.
Do you have to have witnesses or no? Or just
Well, they recommend 2 witnesses, and I think that's a safe thing, but
Right.
yeah, I think
Okay.
if they see it written down and you're signing it, people should be respectful of that.
Thank you.
Dr. Pompei, thank you so much. You just gave us so much great information. And we'll have Kyle, our great communicator, send out a list of all the resources, the one that Judith mentioned and so forth, and then the ones that are in the chat. So in case you didn't get a chance to write it down, so everybody will have that. And what a great presentation, and how impressive. I just can't believe all those wonderful, wonderful credentials. And it was really fun to learn that part of Dr. Pompei. And on another quick note, our next program for gen2gen will be a barbecue on May 17th at noon at Cuesta Park. And part of the celebration will be honoring Pastor Zhang as he leaves for his second part of his renewal leave, June 11th for several months. So we'll be hearing about his adventures to England and Scotland and South Korea and so forth. So mark your calendar. You don't need to RSVP, and it'll be a great fun barbecue with fellowship and fun and food. So thank you for that. And again, thank you everybody, and much appreciation,
So
Dr.
much,
Pompei.
Dr. Peter. And